Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jennifer Swanson. Today's episode features content from an educational program titled Contemporary Management of HIV. During this podcast, Dr. David Wohl from the University of North Carolina discusses initiation of first-line antiretrovirals in treatment-naive adults with HIV. Specifically, he'll discuss a case of a patient who is co-infected with HIV and hepatitis B virus and has a body mass index of 32. For more information on Dr. Wohl and a link to the full online educational program, including downloadable slides, please visit the show notes for this episode. Now, let's get started and hear what Dr. Wohl has to say about a case of initiating first-line ART in a patient with HIV, HBV, and obesity.
Okay, this moves us on time really nicely to a quote-unquote older woman. Older, you'll see she's not that old, newly diagnosed with HIV. She's 54, which I don't think is that old. And she's a woman newly diagnosed with HIV. She has some glucose intolerance and hypertension. She is hepatitis B DNA PCR positive, so she does have hepatitis B chronically. She unfortunately has a low CD4 cell count of 200, viral load that is skyrocketed to a quarter of a million, core antibody positive, hepatitis B positive, hepatitis C negative, HLA-B5701, for what it's worth, is negative. Her BMI is 32. So she's got a little bit of obesity. Viral resistance, shows no resistance. ALT and ALST are a little bit upper limit of normal, beyond upper limit of normal. So that may be due to her hepatitis B status. So the concern for her, and if I was advising this woman, and it was mentioned that she's African-American, and that may be important here. In most cases, it's not. Here it might be because of data that we'll see here that shows in some of the studies that we've looked at weight gain after starting HIV therapy. There are some differences based upon drug class and specific agent, and also on demographics. Here's a pretty nice analysis of a whole bunch of studies that were done by one manufacturer, by Gilead, looking at a bunch of different regimens, including integrase regimens, PIs, and NNRTIs. And what it shows overall across these different graphs is that integrase inhibitors, going left from right, integrase inhibitors are associated with greater weight gain over a couple of years after starting HIV therapy compared to PIs and NNRTIs. People gain weight. When you start HIV therapy, especially in the olden days where we would wait until people's T cell count went down and then rebuild that back up, people tended to gain weight. Even now, we see with people starting therapy earlier, there's still weight gain. But disproportionately above that return to health weight gain, we're seeing increases in people on integrase. When you go over to the right, to the middle one, it looks like bictegravir and dolutegravir. Again, they're kind of twins. They do about the same compared to elvitegravir, cobicistat. And I would argue if you had data on raltegravir, which we didn't in these analyses, in these studies, probably look a lot like the elvitegravir, cobicistat. So bictegravir and dolutegravir of the integrase inhibitors, more weight gain. And I should point out, we're talking about the change in weight here in kilograms. So kilogram, right? So kilogram to pound, it's about 2.2 pounds, right? So per kilogram. So this is a lot of weight. This is a significant amount of weight over a 2-year time. And then when you look at whether it's TAF or TDF or abacavir or AZT, it does look like TAF on top of whatever's happening with the integrase inhibitors is associated with greater weight gain. And we don't understand completely if this is, well, TDF makes your weight not go up, just like it doesn't make your lipids go up, or is it TAF intrinsically making you gain weight? It's probably the TDF suppressing weight gain, but for someone taking the medicine, it doesn't matter what the mechanism is. All that matters is that I'm gaining weight because I'm on TAF and I'm not on TDF. So that's what I think is going on here. So TAF is associated with greater weight gain, bictegravir, dolutegravir, greater weight gain, and integrases, greater weight gain. The study that really makes this abundantly clear is this one. This was done in South Africa. It's men and women starting HIV therapy straight out, 3 different options: efavirenz, TDF, FTC, or dolutegravir with TDF, or dolutegravir with TAF. And that's it. And these are just basic 3 very reasonable regimens to start folks in. And again, efavirenz has been a workhorse in many parts of the world for many years. It's being supplanted, as we talked about, for good reason, with integrase inhibitors like dolutegravir. So this is a head-to-head study, randomized, blinded. Everyone is Black in the study. Half are men, half are women. And all three worked really well at suppressing the virus. People take their medicines and these things work. So there was no difference with virologic suppression, really. But what there was a difference in is weight gain. So there was a difference in weight gain based upon what regimen you started. Again, everyone basically gained weight, but disproportionately people on dolutegravir gained more weight than people on efavirenz. And if you are on TAF as opposed to TDF, you gained even more weight. And women gained much more weight than men. Again, if we do the conversion, you're talking about 6 kilos. That's like 12 pounds. And then if we look further out, the weight gain kept going and going and going. So certainly something going on with dolutegravir, TAF, FTC that leads to greater weight gain than we're seeing with the other two arms. And again, the other two arms had TDF. Was TDF suppressing it? Maybe. But still, phenotypically, these are people who are gaining a lot of weight. And for women, it was much greater than men. That's being pretty consistent when we see, even in the study I showed before, that's pretty consistent. And people of color, we're seeing more weight gain than people who are not of color. There's other data. These come from the United States, so we have a little bit more data that's closer to us that shows that in people who switch from TDF to TAF and keep everything else the same, there is a bump in weight. Again, is that the lifting of the suppression of weight with TDF? Maybe, and that's what's suggested a little bit by PrEP studies, where people on TAF or PrEP don't really seem to gain much more weight than what you'd expect in the general population, whereas people on TDF don't gain the weight that we'd expect in the general population. So I think there's a good story there. But if you switch to TAF and also switch to an integrase, you're more likely to get a more substantial weight gain. And again, with bictegravir and dolutegravir being more likely to lead to that kind of weight gain than something like elbictegravir. So if I was to see this woman, I would be very clear that I would be worried that given her BMI is already 32, she's starting therapy, it's likely she's going to gain weight. And if I start her on bictegravir or dolutegravir and TAF FTC, she may or may not, it's not universal, she may experience weight gain. And that may be something that I would want to watch and track. And if it does happen, not blame on her and her eating habits, but really understand the culpability is on the medicine that we probably started. So here it is. So how do you counsel patients regarding what is known about weight gain with ART? And you can read through, we'll give you some time to look through these options and then pick the one that makes the most sense to you. You guys are going to knock it out of the park. Okay. Right. So most of you did. So ART is associated with weight gain that appears to be higher for integrase inhibitors versus the other classes. Okay. Let's go to the next. Here we go. So let's go through them because I think it's really important. So the first one is ART is associated with similar levels of weight gain. We know that that's not true. I just showed you graph after graph in multiple colors that there's differences between these different things. Okay. ART is associated with weight gain that appears to be higher for integrase inhibitors versus boosted PIs and NNRTIs. Ding, ding, ding. Correct. We showed that pretty clearly in a lot of different studies. C was ART is associated with reversible weight gain that is lost when the problematic drug is discontinued. I give you guys credit. The 22% of you who said that, that's pragmatic and that's probably true. We didn't talk about it. We don't know. But I think you all got, if whoever said B and C, which I think is almost everyone, I count you all as right, because that's right. And then D, ART is associated with weight gain that appears to be higher for boosted PIs versus integrase and NNRTIs. If you chose that, it was because you meant to choose B, but D sounds like B and you just hit the wrong one. What about hepatitis B? She's got hepatitis B. What are we going to do about that? So that's another important thing. And that's the good thing about TAF and TDF. They work against, they're the best hepatitis B drugs out there. So we do know that in people living with HIV who start on a TDF or TAF-based regimen, their viral load for the hepatitis B is more likely to go down, especially if they didn't have a super high, big viral load, hepatitis B viral load to begin with. And then here again, it's good that she's quote unquote older, because the time to suppression for people who are older to get their viral load down for hepatitis B is less compared to younger people. So age wins. So she did a great job. Hopefully for her, starting on a regimen that has TAF or TDF, we'll see that viral load drop, and then hopefully she won't have to worry as much about hepatitis B. So that's a good thing about these TDF drugs or TAF drugs. That's why she wouldn't be a good candidate, of course, for something like dolutegravir 3-TC. The dolutegravir would still cause the weight gain risk, and she wouldn't be protected for hepatitis B, which is what she needs. So that wouldn't have been a good option for her. There is evidence of seroconversion when you do have good HIV therapy. Again, this is what we want. It doesn't happen in everyone. It doesn't happen in the majority, but it does stack the odds more towards your favor if you're on a tenofovir-based regimen, that your hepatitis B antigen could be lost, and eventually maybe some of those people will get antibody. Different guideline panels, whether it be the AASLD or EASL, have talked about using hepatitis B active HIV therapies for people. A lot of words here that basically say just do that if you can. If you can't, entecavir, which is a hepatitis B specific drug, should be used. But just keep mindful, we don't have a whole lot of hepatitis B in the United States, but we have some, and we should just check for it. And if someone is hepatitis B surface antigen positive, we should really be making sure that we're treating the hepatitis B and the HIV. And that's what all these words say. So as far as weight gain, this is really one of the bigger concerns. Before the COVID pandemic and everyone gained, 20 pounds, this really was something we were thinking a lot about. And I think we have to continue to work on this. There are clearly risk factors for gaining weight on HIV therapy, whether starting HIV therapy or switching. And I didn't show you switch data because this is a first-line regimen talk, but except for that OPERA cohort, if you switch to an integrase inhibitor, especially if you switch to an integrase inhibitor and get rid of TDF, you could see some weight gain. So we just have to track it. I think that's the key thing, and just be, very aware. I know many of us feel like, well, my patient gains weight for a whole bunch of reasons because they don't eat well, they don't exercise. That's true, but this is when it's related to the medicine. It starts soon after. You can see from that study from the advanced cohort, the advanced trial, it didn't take years. This popped up pretty quickly. So just be cognizant of it, measure weight, follow weight carefully, especially when you're making these changes to people's regimens. On the integrase inhibitors, especially newer integrase inhibitors, TDF, and versus TAF. TAF seems to be associated with greater weight gain for the reasons that we speculated. We don't understand the mechanism, and we don't understand if we switch, does it go away? Anecdotally, I could tell you that when we switch our patients, it has gone away or gotten better. But people also start to do more as far as limiting their calories and exercising, so that may be a factor too. And then for co-infection with hepatitis B, HIV, I think we have a good sense of what we need to do and good tools to do it. So there's a good question from Brian. Many of our patients have multiple comorbidities, including diabetes. Looking at weight gain as a factor to select the most optimal ART therapy in patients with HIV and diabetes, which regimens do you prefer to minimize metabolic complications associated with weight gain, excessive weight gain? It's a really good question. So there's some trade-offs or balances here. So there's the potential for weight gain with the integrase inhibitors that we talked about, whether it be dolutegravir or bictegravir. So that has to be offset maybe by, well, what else do we do? So for the Department of Health and Human Services, I'd say for the IS USA, there's nothing there that can help. It's all bictegravir or dolutegravir. And really the only thing in the Department of Health and Human Services guidelines that might be an option from the recommended list would be raletegravir. The idea being that raletegravir would be less associated with some of the excessive weight gain. And that makes some sense. But now you're talking about more than one pill, not co-formulated. And so now you're getting into trade-offs. And if we do something like TDF and not TAF to kind of blunt some of that integrase bump in weight, well, now you're exposing someone with diabetes and hypertension maybe to a drug that can hurt the kidney. So I'll tell you so then you might say, well, I'm going to go, rogue, and I'm not going to use the recommended list because I have a woman who's African-American and is already obese. I'm not going to take the chance of giving her something like that. So I might give her doravirine. And that doravirine might be fine with, or even rilpivirine, TAF, FTC, if she's willing to take it without, with a meal, which paradoxically is what you don't want people to eat too much, but you're telling someone to take medicine with a meal, and also no H2 blockers or PPI. So everything's a trade-off. So there's no good, this is why this is such a vexing issue. There's no good answer here. One approach might be do the BF-TAF and just see what happens and just watch it really carefully. And at the first sign of excessive weight gain, then maybe pull back and then switch. So I don't have a great answer for you. I warn people about it and with them try to make some decisions. I have had people say, look, I've been battling weight. I don't want anything that's going to make my weight go up. And it's a conversation we have when we talk about SSRIs, right? Or antidepressants, same sort of thing. That they don't, why don't you start me on a regimen that is less likely to make me gain weight? And that might, in my book, be a doravirine-based regimen.
Well, thank you very much to Dr. Wohl, and thanks to listeners for joining in. As a reminder, to view the full educational program, Contemporary Management of HIV, on the Clinical Care Options website, click on the link in the show notes. And please check back regularly for more episodes on important infectious disease topics. Thank you, and have a wonderful day.